Hi, my name is Dr. Vikas, and I'm one of the chief neonatologists and pediatrician here at Motherhood Hospital Hospital. And I would like to take you through just a tour of our NICU, which basically is a level 3 neonatal intensive care, catering to almost everything. So we take care of the preterm babies, birth cesareans, cooling, nitric oxide, pediatric surgeries, and we also have pediatric cardiology medical services here also. So we have a full-fledged services here in our unit. This unit basically has many beds, and we are standing now is currently a place which can hold about 15 beds, and we have one more unit on the other side which can hold about almost 4 babies, which is basically an isolation bay. So in total we do about at any given point of time about 14 to 19 babies can be easily served here. We cater to different varieties of pathologies in our setup, which basically it could be term gestations with various problems, like we have a baby there which has many issues in terms of the skin, and we have preterm babies which are recuperating and basically the feeders and grows and basically are planning to go home. So these are usually 30 to 34 weekers. They also get usually admitted here. And one of the sick ones that I'd like to bring to your highlight is basically the babies on my left, which is extreme preterm twins. They were born at 26 to 27 weeks gestation, where we don't have an accurate estimate from the referring doctor, but we do know that they were born in a very poor condition. They were born twins, and they were around 750 grams at birth. When they were born, they had very bad infection. Unfortunately, they did not have the advantage of having steroids or magnesium sulfate, which we usually give in preterm babies, so because they just the mother came and delivered the babies. Now, if you I want to highlight this baby on the left, which is this baby basically. Is doing currently well now. As you can see, is currently on CPAP, but this baby underwent a lot of difficulties. Was having very bad respiratory distress. We required almost 2 to 3 doses of surfactant. Went on to high frequency ventilation. We do high frequency ventilation in our unit, so this baby required high frequency ventilation. Had difficulties with the lungs. And we had very high carbon dioxide levels, were unable to wash out, so the high frequency ventilation. This baby was almost ventilated for 8 to 10 days at a stretch. This baby not only had problems with ventilation requiring high frequency ventilation, but also had a lot of issues with the heart. This baby's heart was almost failing, was not working, and this baby had very poor cardiac output, which required a pediatric cardiac specialist to be involved. We managed this case together, wherein this baby was on very high inotropes. So usually preterm babies are not started on milrinone and NORAD, but this baby went on to have milrinone and noradrenaline and dopamine. So this baby was actually effectively on 3 inotropes. So the fractional shortening was less. We were not sure how the cardia would go, but we counseled the parents, we told them the condition, and they gave us a lot of hope actually to continue with the care, and we went on with the care, and now I'm glad to say that this baby recovered from the cardiac insult. This was basically a toxic myocarditis, resulting in very poor cardiac function, lot of swelling, very poor cardiac output, but in the end this baby recovered very well. Now this baby's current problems I would say is, now this baby is almost 30 weeks old now, so we are trying to establish feeding in this baby. Other than that, this baby is really doing well. So this is one of the twins. This is a twin 2. If I just move your attention to this other baby, which is here, is a twin 1, almost born in a very similar condition. This baby's cranial ultrasound has been absolutely fine. Is currently also, like I said, of the other babies are 30 weeks old currently, doing very well, but did develop necrotizing enterocolitis now in its 3rd week. This baby developed necrotizing enterocolitis in its 3rd week, but this baby, like the other twin, also underwent a lot of problems in the initial stages, requiring multiple doses of surfactant, requiring high frequency ventilation. Luckily, this baby didn't succumb to toxic myocarditis like its sibling, and we didn't have to use a lot of inotropes, but we did have to go up on their antibiotics. So we used almost a 4th line antibiotics, and now currently this baby had neck, but our pediatric surgeon has been very kind enough to give the input on that, and we have just done a small nick into the abdomen to release all the gas. Luckily, the perforation in the abdomen has sealed off on its own, so we will not be doing further intervention for this baby or an ileostomy, which is lucky for this baby because we are not taking out any gut, which would have been problematic for this baby with short gut syndrome. We hope to leave this baby alone like this for another 5 days, and then hopefully give start feeds. And our pediatric surgeons have been very optimistic in terms of giving the input, saying that hopefully we should be able to establish feeds in this baby soon. Both these babies, as you see, are usually being fed through a total parental nutrition, full total parental nutrition, and we do follow the ESPAGAN guidelines for total parental nutrition. They do get weekly. They get scans as per the protocols, so they have day 1, day 3, day 7 scans, and further on depending on their pathologies. I must say these parents have been very supportive. We do counseling very regularly, twice daily in our counseling rooms, and we tell them about what's happening with the condition of the baby. Currently we are not using much equipment for these babies, but these babies are the ones I would say went through level 3 plus care, requiring high frequency ventilation, lot of cardiac support involving cardiac surgeons, and now we are involving the pediatric surgeons. So this is kind of a level 3 neonates who require a lot of inputs. Most of these do very well with the care, and they do go home, and we do have a lot of examples. We have recently discharged a 25-weeker who went home doing really well, was born at 700 grams and is currently about 1.7 kgs. So basically this is the kind of work we do here in our unit. We do bring babies from a lot of places. We do have a very good transport facilities with a very good transport ambulance and a very good transport incubator to help us bring babies from all over the places. I would like to tell you about these two babies here we have, which are on currently on phototherapies behind me, and these are basically 33 weekers. So these are basically level 2 babies who were delivered by cesarean section because of preeclampsia, and they basically had all the antenatal steroids given which is required, still ended up having respiratory distress syndrome, so they went on to have CPAP. We do not give surfactant unless there is a clinical requirement, so these babies were not given surfactants, and they did very well on CPAP. They are on to day 3 of their life, and one of the twins has come off CPAP, and the other twin is still on CPAP, which are planning to go to Optiflow sooner, hopefully by tomorrow. These babies were fed early, and we do start feeding early in our unit for all preterm babies, including the extreme preterms, and we try to establish the feeding as soon as possible. So usually if mother's milk is not available, we try to use the donor milk, but we never use formula milk for less than 34 weekers. So the advantages of mother's milk is early maturation of the gut and better clinical outcomes and early discharges, and less infection risk. So this is the biggest advantage we have with the mother's milk. So we try to get the mother's milk. We liaise with our obstetricians and get the mother's milk. If it is not available, we do go for donor's milk, which is proven very beneficial. There's a lot of data now that mother's milk or donor milk reduces the incidence of neck, so we do advocate that, and formula milk is totally avoided. These babies are almost on full feeds now, and basically waiting for the respiratory support to go off. If you can see this baby has come off CPAP onto what's called as a high flow nasal cannula oxygen air mix. So that's a bit of a respiratory support, not requiring full care, full intensive CPAP, which basically is the next step in the form of weaning. So the lot of problems associated with CPAP, like sore ulcers, pressure ulcers, are usually avoided with the use of high flow nasal cannula oxygen. As you can see, this is the equipment that basically houses the high flow nasal cannula. Babies are very comfortable, they can feed well, tummy distension is very less with that. So in summary, basically we cater to a variety of pathologies for different age group of neonates, basically from 24 weeks onwards up to 34 weeks in this NICU. So there's 10 weeks of gestation with full support, be it either respiratory, cardiac, endocrine or metabolic, dermatological, neurological. So varieties of support are provided here, and it is basically an integrated, holistic approach that we aim to provide at Motherhood Hebbal. Thank you very much for listening.